So this presentation is going to be on right iliac fossa abdominal pain. My name is Amanda and I'm a senior house officer in the general surgery ward at the JR. And this presentation, along with Mahul Patel, will focus on the right iliac fossa. So the abdomen is split into 9 regions. Specifically, the right iliac fossa contains numerous organs. So, for example, the appendix, the cecum, the terminal ileum, in females, the ovaries, as well as the ureters. Now, these are all organs that can lead to right iliac fossa pain acutely. And today I was planning to go through some cases to demonstrate some of the most common diagnoses that you might find when working on the general surgical wards. So the first case is a 43-year-old female. So you're working on the general surgery ward and female comes in with 24-hour history of right iliac fossa pain. She's not been able to eat or drink very much since yesterday, saying that she has a reduced appetite. When you ask her if she feels feverish, she says that she's had hot sweats during the night. She's also been vomiting. And also for the last 10 hours, she's been having on and off diarrhea every time she tries to open her bowels. So there are numerous differentials that we need to consider in this case. And the way I think it's good to do it is to split it into different specialities. And that way, when you get asked a question, whether it's an examination or whatever it might be, you have a good structure of demonstrating what the common differentials are. So in this context, appendicitis is quite high up on the differential list. Then you've got your gynecological conditions such as ovarian cyst rupture, ectopic pregnancy is very important to rule out, pelvic inflammatory disease as well. Then you've got your renal system, so ureteric stones, urinary tract infections, as well as pyelonephritis. Then moving on to GI, you've got inflammatory bowel disease, diverticular disease, you've got Meckel's diverticulum. And interestingly, when you do, if you do diagnostic laparoscopy for appendicitis and you find the appendix to be normal, usually you'll need to go ahead and check if there is an inflamed Meckel's diverticulum. And it's important to remember the rule of 2s, which is 2% of the population. It's about 2 feet from the ileocecal valve, about 2 inches long, and tends to occur in those that are under the age of 2. Other important conditions not to miss are urological conditions such as testicular torsion. And specifically in children, other differentials can include acute mesenteric adenitis, gastroenteritis, constipation, intussusception, as well as also urinary tract infections. So going back to the same case, go to examine the patient now, and we find that the lady she's slightly dehydrated. She's got pain in the right iliac fossa at rest. So even bedside examination is very important. You can see that she's clutching at her right side before you even go to palpate the abdomen. Her heart sounds are normal. Her chest is clear. The abdomen is soft, but she is maximally tender over the right iliac fossa with rebound tenderness as well as guarding. So we need to think now, what kind of investigations, considering the differentials that we mentioned from earlier, are going to be important or relevant to rule out other conditions that might be going on. So urine dip is important, specifically, so you'll be able to rule out things like urinary tract infections. So if you've got positive leukocytes as well as nitrites. Also, it's quite important in terms of ureteric stones. So if you find, microscopic hematuria, you're going to be thinking that the patient might also have ureteric stones. So that's quite important in the first instance. And then obviously for females, pregnancy test is extremely important. to rule out ectopic pregnancy. And then moving on to bloods. So mainly you're going to focus on white cell count and CRP to see if there's any raised infection as well as inflammatory markers. So that will kind of point towards an appendicitis picture. So depending on how long their symptoms have been, you'd expect the white cell count and CRP to correspond with that and increase as the days go on. Also, imaging is also used. So for this female, we need to think about what kind of imaging we would use. So a female that's, under the age of 40, we try to steer away from doing CT scans because that promotes, quite a lot of radiation to the ovaries. And in the first instance is not what we would do. And we must not forget that, a diagnosis of appendicitis is clinical. But ultrasound scans can be very useful, specifically transvaginal ultrasound scans, to rule out your ovarian pathologies such as cysts, ovarian torsion. So usually on the surgical department, we will order this in the first instance just to make sure there's nothing gynecological going on. In those that are over 40, that's when we tend to do CT scans because it has a very high specificity. It's very sensitive to those that have appendicitis and is likely to show up the diagnosis if, for example, you weren't 100% sure based on symptoms and examination alone. So in this case, we've done a CT scan that has demonstrated that the patient has acute uncomplicated appendicitis. So I'm just going to go into a bit of detail as to what appendicitis is. So appendicitis is acute inflammation of the appendix. It is most common in the second or third decade of life and has an overall life kind of prevalence of 7 to 8%. Now it's caused by obstruction of the appendiceal lumen, which is usually secondary to lymphoid tissue hyperplasia, but is sometimes also secondary to a fecalith or foreign body. Now, when this becomes obstructed, bacteria in the appendix can multiply, and that results in acute inflammation as well as distension. If this is left untreated, then ischemia within the appendiceal wall can result in necrosis, which can then go on to cause the appendix to perforate. So symptoms. So appendicitis typically presents with migratory abdominal pain. So peri-umbilical pain, which is usually classified as dull, which then later on goes on to migrate to the right iliac fossa, is your kind of classic cardinal symptom. And the reason for that is the appendix tends to be poorly localized when only the visceral peritoneum is affected, as the splanchnic nerves is very poor to localize. Whereas once the parietal peritoneum is involved, then you get more specific kind of localization to the right iliac fossa. Other symptoms include nausea, vomiting, anorexia, diarrhea, as well as constipation. They typically have a low-grade fever. And then on examination, the most common sign is rebound, tenderness, and percussion pain over McBurney's point, as well as guarding. So McBurney's point is 2/3 of the way along from the umbilicus to the anterior superior iliac spine. So this is specifically tender in acute appendicitis. Another sign is Rovsing's sign. So that's where you get palpation of the left iliac fossa causing pain in the right iliac fossa. Psoas sign, which is right iliac fossa pain with extension of the right hip. And this is quite useful in diagnosing appendix that is in the retrocecal position. As I mentioned earlier, it's important to remember that classical signs and symptoms, if they are present, then the diagnosis of appendicitis is clinical. and we don't really need to go on further to do more imaging. However, in females, given that the ultrasound scan, a transvaginal and transabdominal ultrasound is very non-invasive, it might be worthwhile doing that in the first instance just to rule out your gynecological conditions, given how close the ovaries lie to the appendix. Investigations, we mentioned this earlier, so urine dip and MSU. Pregnancy tests, always remember to do that. Your routine bloods looking for infection and inflammatory markers, as well as the workup to potential surgery. So you want to do your group and save, you want to do your clotting, other things like your COVID test, PCR. And imaging, we've gone through this, I'm not going to repeat it again, but as I mentioned earlier, it's not essential to diagnose appendicitis as it's a clinical diagnosis, but ultrasound scan and CT abdo-pelvis are the images that can be used depending on the context. Now, management. So the definitive management for appendicitis is a laparoscopic appendicectomy. You take the appendix out. In our trust, the diagnostic laparoscopy, if it finds that the appendix is normal in appearance, usually we would still go on to take the appendix out, just so that if the patient were to present with a similar symptoms in the future, we know that it wouldn't be secondary to appendicitis. During the laparoscopic diagnostic laparoscopic procedure, we would be looking at the colon, checking that there is no other causes for the right iliac fossa pain, and we'll be checking Meckel's diverticulum, as I mentioned earlier, making sure that that hasn't caused the symptoms. And in females, we'd also check for any kind of ovarian pathology whilst we're present as well, checking the fallopian tubes, making sure there's nothing else going on in terms of that. Now, there's been some debate surrounding the use of conservative antibiotic therapy, especially in uncomplicated appendicitis. However, antibiotic therapy alone has shown to have a failure rate of about 25 to 30% at 1 year. So again, the key is that management is more kind of steered towards doing a diagnostic laparoscopy and removing the appendix. But antibiotic therapy may be relevant for those that may not be fit for surgery. Complications, some of these we mentioned. So if it's not treated, then it can perforate and that can lead to peritoneal contamination. You can also have surgical site infection, an appendix mass where the omentum and small bowel adhere to the appendix, as well as pelvic abscess, which tends to present as a fever with a palpable right iliac fossa mass and can be confirmed on CT scan. And management of that would usually be antibiotics plus or minus drainage. So the second case is a 65-year-old male that's presented with right-sided abdominal pain. He says that it comes and goes in waves, but is usually there as a dull ache in the background, and he can't keep still due to the pain. So the differentials in this case would be, for example, renal stones would be high up on your list. Biliary colic, again, that presents as a colicky abdominal pain on the right side of the abdomen, but higher up. Don't forget dissection of an aortic aneurysm. So specifically if a patient is over the age of 60, it's always important to consider the loin pain, especially if they're hypotensive and they're known to, for example, have hypertension as a baseline. That is particularly worrying. Pyelonephritis usually presents with a very high temperature, and it's unlikely to radiate to the groin, but can present as a right-sided loin pain. Acute pancreatitis, you've got acute appendicitis, perforated peptic ulcer, torsion of the testes. So always check the testes on these examinations of a patient that comes in with loin to groin pain. And then, of course, there's other causes of back pain. So it's important to examine the vertebra. So on examination, the abdomen is soft, there's tenderness in the right flank, bowel sounds are normal, there's no organomegaly, Murphy's sign is negative. So again, you're thinking gallstones, trying to rule that out. So investigations in this case would be a urine dip once again, because as I mentioned earlier, you want to see if the patient has any signs of infection. Are there any blood? Is there any blood in the urine? What is the pH of a urine? In a patient that has urinary stones, that's particularly useful to determine what kind of stone the patient has. Bloods, you're going to check for infection and inflammatory markers again. Imaging. So if you're thinking renal stones, CT, non-enhanced CT scanning is the imaging of choice. And ultrasound can also be useful to differentiate radiopaque from radiolucent stones, and also in seeing if there's any evidence of obstruction. And often plain abdominal x-rays are used of the kidneys, ureter and bladder, which is useful in showing the passage of radiopaque stones. And about 75% of stones are calcium and so will be radiopaque. So this is just a CT scan demonstrating a renal stone. So what is the management of renal stones? So in the first instance, analgesia, so NSAIDs are particularly useful, particularly IM diclofenac or PR diclofenac, especially as the patient is likely to be nauseous and maybe vomiting. So it might not be appropriate to give them oral analgesia in the first instance. Antiemetics are therefore very important. Fluids, also smooth muscle relaxants. So you've got your alpha receptor blockers such as tamsulosin, and then you've got your calcium channel blockers such as nifedipine. And this can help with the passage of the stone. You'll need to consider hospital admission. So for example, patients that have a fever, if they've got an infective obstructive system, if the patient, for example, only has one kidney or their kidneys aren't working particularly well, these are all patients to consider admitting. Many stones do pass on their own. So if the stone's less than 5 millimeters, it usually passes spontaneously in up to 80%. If it's 5 to 10 millimeters, then it will pass spontaneously in about 50%. And if it's larger than 1 centimeters, then usually these are the patients that will go to surgery. And they'll go to surgery more urgent if it's a complete obstruction or if there's any signs of infection. This picture on the right is showing common sites of obstruction. So you can get obstruction in the renal pelvis, the pelvic ureteric junction, as well as the vesical ureteric junction as well. When the patient has symptoms or imaging that shows that they have a completely obstructed system, then a JJ stent is usually inserted in the first instance. And then later stone is removed. So it can be done by extracorporeal shockwave laser treatments. You could consider percutaneous nephrolithotomy, which is used for larger stones more than 2 centimeters, or if there's a staghorn calculi, and also if there's any cystine stones. And open surgery is usually not utilized in this day and age, but can be used if there's complicated cases or if there's a patient that has recurrent stones. This slide is just showing the types of stones. So calcium stones are the most common stones. Uric acid stones often do not show up on X-ray, and on the urine dip, they tend to have a pH of under 5. Struvite stones, they're the ones that tend to cause staghorn calculi and also are associated with infection, and they tend to have a higher pH. And finally, cystine stones, which tend to be, can be genetic. Last case, so you've got a 24-year-old female coming in with right iliac fossa pain, vomiting and fever. There's one investigation that I don't want anyone to miss out, and that is the pregnancy test. Regardless of the sexual history that you take, it's always very important to do this test and to let the patient know you're going to be doing this check, as it's definitely, you do not want to miss an ectopic pregnancy. So this slide is just going through some common gynecological pathologies. So I'm not going to go through this in too much detail because that will be covered in another lecture, but it's just to highlight some of the main conditions that might also present with right iliac fossa pain. So ectopic pregnancy, as I've mentioned. So these women usually present with 6 to 8 week history of amenorrhea and sudden onset abdominal pelvic pain, which may radiate to their shoulder. For example, if they have a ruptured ectopic pregnancy, often have vaginal bleeding with or without clots, and they might have more severe symptoms of hemodynamic instability, such as collapse, shock, and dizziness, which will make you particularly worried that there is a ruptured ectopic pregnancy. And on examination, they'll have adnexal as well as cervical motion tenderness. Another condition is pelvic inflammatory disease. So typically these patients, you need to ask them about STI risk factors for sexually transmitted infections. For example, having a new sexual partner recently, not using contraception. They may come in complaining of purulent discharge, feeling feverish, typically have bilateral lower abdominal pain, deep dyspareunia, and in a female, abnormal vaginal bleeding, so intramenstrual bleeding, postcoital bleeding, etc. Another condition is endometriosis. So typically this presents with cyclical and chronic pelvic pain as opposed to an acute pelvic pain situation in the case of an appendicitis, for example. So this will come and go with the period and will be something that has existed for a while in the patient. They'll also have dysmenorrhea and deep dyspareunia as well. And this is a gold standard diagnosis via laparoscopy. Fibroids, again, this can present with cyclical pain. Typically, they'll have menorrhagia, and they may have a palpable mass, which typically arises from the pelvis, as well as an enlarged, irregular, non-tender uterus. And then finally, another one I chose to include was ovarian cyst or torsion. So typically, these patients present with a sudden onset lower abdominal pain, which in the case of torsion might include intermittent episodes of severe pain. They might have vomiting, they might be peritonitic, especially if they've got a ruptured ovarian cyst, and they might again show signs of hemodynamic instability and shock. And again, ultrasound, that is why it's key in a female to do a transvaginal, transabdominal ultrasound. It's very non-invasive, it's cheap, just to rule out these ovarian pathologies prior to considering other diagnoses. So thank you very much. I hope you found that helpful listening to this video. I've put some feedback forms which I'd kindly appreciate if it could be filled in, one for myself and one for Mahul. And I hope if you have any questions, please do comment and let me know.